Jeff, do you think we should start?
Yeah, I think so.
Why don't you go ahead, Jeff?
Sure. Hi, everyone. Thank you all for joining us today on this Tuesday afternoon. My name is Jeff Ladolter, and I am the program manager for the Tribal Opioid Response Technical Assistance Grant through the National American Indian and Alaska Native Addiction Technology Transfer Center, or the ATTC. Our ATTC is actually a network of ATTCs across the country, and you can learn more about them by visiting our homepage, which you can find in the Contact and Support box. This webinar is brought to you by the Substance Abuse and Mental Health Services Administration, and we are lucky enough to have two government program officers on the call, Amy Romero and Will Longinetti, who will be giving a short address at the end of our presentation. At the end of this presentation, you will be redirected to a GPRA survey, which we use to gain feedback on our webinars and help continue bringing these webinars to you. It should only take 15 minutes or 5 minutes to fill out the survey, and it would really help us if you do. We also offer continuing education units, and if you would like to learn.
Jeff,
Ana Helena, would you mind introducing yourself?
Okay. I just want to correct one thing, Jeff, and that is that we have a flat rate for CEUs, but we don't charge $15 for this one since it's only one day. But anyway, my name is Ana Helena Shinsta, and I am a clinical professor at the University of Iowa College of Public Health and also the project director of the National American Indian and Alaska Native TTCs. As you can hear, I have an accent. I'm Norwegian, and I have been in this country working with Native communities and providers for 30 years. So I came and never went back. As beautiful as the country is, I love working in the US and with tribal communities. So enough about that. My clinical interest is very much in women and Native American issues and in workforce development issues. So, Matt, you are next up.
Skokdash, my name is Matt Ignacio, and I'm a member of the Dahana Nation. I'm currently calling live from Seattle, Washington. I work for the ATTC. I work alongside Jeff and Ana Helena and the crew as a research support manager. I have over 21 years experience providing direct service, providing technical assistance, providing volunteer service, unpaid help for HIV prevention programs across Indian country, whether it be urban communities, whether it be rural reservation communities, whether it be island and village communities, including the communities we work with in Alaska and Hawaii. I'm excited to be here. Part of my passion really is addressing drug and alcohol use among Native people from a harm reduction perspective. I'm a harm reductionist. I'm also a doctoral candidate. I'm graduating in a matter of weeks, and so I'll have a PhD in social welfare from the University of Washington School of Social Work. It's my honor to be here, and I'm so glad you took time out to join us, so thank you. And so we just want to have a kind of, thank you, Jeff, for the introduction. We just wanted to talk about, kind of give you a little snapshot of what we hope to chat about over the next, I think we have the time reserved for an hour and a half, but we certainly want to leave time for discussion, and we certainly want to leave time for questions, and our GPOs on the call, if they have some additional thoughts, we want to create time for that. So if you have questions while we're presenting, if you wouldn't mind, just go ahead and entering them in the chat box. You can see the chat feature down on your screen. And then if we don't stop periodically, we will definitely address the questions as we proceed through the presentation. Jeff will be watching out for those as you type. And if there's any issues with audio or clarity, please feel free just to use the chat box as well and let us know if maybe perhaps it's too quiet and you can't hear the volume. I can certainly adjust things on my end to hopefully meet your needs. Okay, so let's talk about what we hope to accomplish today. So we want to talk about, we'll cover some learning objectives. We really want to get into kind of the meat of today, and which is to provide a little bit of a historical overview of contingency management. We certainly want to dive into what exactly contingency management is, and we'll offer some learning principles. In addition to, we'll offer some examples of contingency management in practice. And then we'll also have a discussion about contingency management as it applies to Native communities. And then we have a brief conclusion, and then we'll wrap up, and then we'll open up the forum. So with that, I am going to read this slide, and then I'll hand it over to Annalena momentarily. So the objectives for this awareness training, first off, is to understand how contingency management programs can enhance treatment outcomes and facilitate patient recovery. We also hope to identify key behavioral terms, definitions, and principles underlying successful contingency management programs, particularly as it relates to Native communities, right? We certainly want to describe contingency management strategies, particularly with regard to evidence-based publications and peer-reviewed publications. And we'll look at specific data around the use of contingency management in and among Native communities. I also want to just quickly acknowledge the support from the team at the ATTC, Steve Steiny and Noah, for helping put together this presentation for you all today. Oh, my bad. I guess it's my turn. I'm going to be talking about the historical overview. And then I will hand it. What's that?
Yeah, no, I'm just jokingly saying this.
Trying to quickly hand it off, right?
Yes,
This is my section, and let's talk about the historical perspective with regard to contingency management. Well, first off, let's just point out the fact that there have been decades of evidence, that there is a history of research, there's a body of literature that supports contingency management work, and that's been rooted in U.S. history. So in the 1940s, thinking about a token economy, right? Tokens were provided to patients suffering from schizophrenia when they exhibited non-disruptive behaviors, right? So there's that reward system coming into play. And it has been used in schools and in prisons. In the 1960s, following B.F. Skinner, famous psychologists, clinicians, and researchers applied operant conditioning principles using token economies. I'm just going to pause right there. And what do I mean by operant conditioning principles? Well, I have a quick definition here. So an operant conditioning is a form of learning in which the motivation for a behavior happens after the behavior is demonstrated. In other words, we know that all enforcement, whether it's positive or negative, increases the likelihood of a behavioral response. Similarly, if I could say that word, all punishment, positive or negative, decreases the likelihood of a behavioral response. So clinicians and researchers applied operant conditioning principles using token economies to treat persons with major mental health disorders, such as schizophrenia. Operant conditioning principles were then used with patients in treatment for substance use disorders. Drug use is maintained in part by the positively reinforcing effects of the drug itself. In other words, drug use in and of itself has its rewards built into it, right? Drugs are effective because they work. They can numb your pain. They can take your mind off whatever issues are going on. They can, they change the functioning in the brain. And so that in and of itself is a positive reinforcement, right? But what we're trying to talk about today is this need to change the reinforcement structure to reinforce abstinence and other behaviors that compete with drug use and that compete with a healthy life. So this is from the 1960s. In the 1970s, doctors Cohen, Leibson, and Bigelow studied reinforcement principles with patients being treated for alcohol use disorders. Dr. Maxine Sitzer studied using reinforcers with patients being treated with methadone for opioid dependence, right? So this goes back into the 1970s. Reinforcers were earned for treatment attendance or drug-free urine samples. And the use of reinforcers improved retention, attendance, and abstinence. By the 1980s, Dr. Stephen Higgins began studying reinforcement principles with patients being treated for cocaine dependency, cocaine use disorders, right? Patients earn vouchers for drug-free urine screens. Importantly, we should point out that in one study, 75% of the patients who received incentives plus their regular treatment were retained in the 6-month study. That's important. Versus only 40% of those who basically got the treatment. They did not receive the incentives. So you're seeing a 75% engagement rate as opposed to a 40% engagement rate, right? Retention rate. And 55% of patients who received incentives plus treatment as usual achieved at least 10 weeks of continuous cocaine abstinence versus only 15% of those who just received the treatment. So we can point to some data that shows the effectiveness when we use contingency management strategies. Moving on into the 1980s, Dr. Ken Silverman conducted further research with patients in inner city treatment settings and looked at the duration of incentive programs and the magnitude of the incentives that were given out, right? Among patients dependent on opioids who were stable on methadone but continued to use cocaine, adding voucher incentives to treatment increased abstinence from cocaine. A year-long voucher-based incentive program helped patients maintain high levels of abstinence from cocaine and opioids. And Silverman also began studying the effects of differing incentive values. In other words, can we expect more successful outcomes if we, change, increase the value of the incentives that we offer? It's a question that began to emerge. In the 2000s, Dr. Nancy Petrie designed the Fishbowl Method of delivering incentives. We're going to talk much more about that today. Dr. Petrie demonstrated the Fishbowl Method could significantly reduce the cost of incentive programs without losing its effectiveness. And that's a key point, that you can still do this work and actually reduce the costs that it takes, the amounts of money it takes to run such programs. And based on Petrie's work, NIDA, Contingency Management Program NIDA study began a large-scale study called the Motivational Incentives to Enhance Drug Abuse Recovery. Okay, I'm going to hand it over now to Dr. Anna Helena Skinstad.
Thank you, Matt. And let me see if I can do this.
I can do it if you need me to.
No, I managed, Matt. You touched, Matt, on the learning principles. And there is learning principles behind this. So when we start thinking about how we're going to use incentives, we have to decide what is the target behavior. And it needs to be available and clear and easy to detect. And for our situation, if we think about TOR recipients and the patients in this program, being opioid-free on medication-assisted treatment would be the target behavior. Then we have to look at tangible reinforcements. and how we're going to use that when the targeted behavior is demonstrated. And then if we do not see the targeted behavior, then the reinforcers will be withdrawn. So in other words, the founding principles is we identify target behavior, we choose the target population, and in our situation, that is Native American, Alaska Native client who have been using opiates, heroin, and you choose how you want to reinforce the target behavior, and the magnitude of how much the incentive should include, how frequently you're going to provide the incentives, and the timing of incentives, very, very important, and how long we're going to keep going and doing this. So here again is very much what Matt already started talking about, operant conditioning. And that is that we have a targeted behavior that is voluntary, and we want to reinforce that and give the consequence of positive targeted behavior. And what we are thinking and know based on research is that the nature of the consequence will impact whether the behavior occurs again. And of course, if the targeted behavior is to have our clients not use opiates, but stick to medication-assisted treatment only, then that's what we want to see happen more. And we want to use positive reinforcers to increase this targeted behavior. So our thinking is the reinforcement strategies will increase the occurrence of the specific desired behavior by increasing and reinforcing by small baby steps. So we don't reinforce after a month of sobriety. We may reinforce after each time the person comes back and has no trace of opioids other than MAT in the urine. And reinforcers are given at high frequency for small, manageable behavior changes. And again, we want to see this happen more and more. And rewards mark an accomplishment or a milestone worthy of celebration. So if the 1 month of no illicit use of opioids, that's a milestone that we want to really reinforce. And when we think about positive reinforcement, which is usually what we want to focus on, it involves presentation of a pleasant stimuli after a desired behavior occurs, and usually quite quickly afterwards. And another examples of a positive reinforcement is when you go to work every day and you do what you're supposed to do, you perform the expected duties, and you receive a paycheck at regular intervals after you have worked. Let's look at examples of contingency management. What we want to say is that usually we use contingency management in addition to other therapeutic clinical methods. It usually isn't a standalone treatment. And what we have seen through research is that by using contingency management, we motivate patients through stages of change to achieve the identified goal, which is being sober and away from opiates. What we have seen is that by combining treatment as usual with contingency management, we are facilitating recovery. What we need to make sure is that when we choose the targeted behavior we want to focus on when using contingency management, it needs to be an integrated part of the treatment plan that we develop with our clients. And we are going to celebrate every little baby step and big step as we're going to make sure that the client will increase the positive behavior, but also to increase the client's feeling of self-esteem and accomplishment. Because being on opiates for a very long time is often resulting in depression, sadness, lack of accomplishments, and by celebrating the changes, we are also hoping to see increase in self-esteem and feeling of accomplishments. So if you think about this on a timeline, we are looking at the end here as the end goal, and we define that end goal with our client, and we foresee a lot of small steps as this person goes along toward, and we are also making sure that we reward these small baby steps as we go forward. So here is one. You attend a program, you have negative UAs, you continue to attend a program, and you may, if you use a fishbowl approach, decide that this is when a person is allowed to draw and get a reward. Other times you do it differently. And again, you get to draw a ticket every time you accomplish any of these goals. So attending the program, and you still keep providing negative UAs, and you attend programs, and again, you will get regular opportunity to draw from the fishbowl a reward. Sometimes you can start the gas card prior to the program. We know that many of our clients have a transportation issue, and it is related to having a challenge paying for transportation and gas. So this may be one way of securing attending the program. And then at the end, you may be able to accumulate enough tickets to go to the grocery store or buy supplies, and as Matt indicated, possibly clothes, something that is precious to you as a client. You can also have a voucher-based incentives, and you receive a standard voucher for each drug-free urine sample or negative breathalyzer results. The voucher has a cash value that may then be used to obtain various goods, as we looked at the end there, or it may be part of a healthy lifestyle. And it may include gas cards, clothing, movie passes, and you name it. But these vouchers need to have importance to the person who receives them. Or giving vouchers for diapers to a person over 50 who's finished having children a long time ago, that doesn't have any important value to the clients. However, if we're dealing with a mom with small babies and part of the voucher includes opportunity to buy diapers, then this voucher has great value. When it comes to a different way, the Fishbowl Method, here you can exchange a price slip for a select price from a cabinet. So oftentimes when people use the Fishbowl Method, you draw from a ticket and you decide, no, I'm going to give this, I'm going to save up. Or I would like a bottle of shampoo. So what you do is to take the clients to the cabinet, and the client is allowed, based on the value of the ticket, to choose reward in the cabinet. And you select an increasing number of draws each time they display the targeted behavior. So each time they return with a positive, a negative, that's when you are able to get the ticket and build up. What is important is you lose the opportunity to draw from the fishbowl if you have a positive urine screen, but you are still getting reinforcements, you're still getting positive encouragements, but you're not getting a price that day. And then if you are drug-free, you will then start up with one draw. So you start beginning the new process after you have been drug-free. So here you see what the ticket ratio is. And the reason why Nancy Petrie did this was that a lot of complaints were raised that this is too expensive, we can't afford this. So what you see here in the tickets would sometimes say good job, or you get a small reward that would be valued to $1 to $2, larger 20, and a jumbo would be over $80 to $100. And I've been in some of treatment centers where the jumbo price was a small tablet or a little TV. Now this is the value of these are, you know, about 8-9 years old, so I think this is adjusted, but you see the gist of this, that it's saving the person who is in charge of the incentive program money. So then let's jump to contingency management in Native communities, and I'm going to hand that over to Matt.
Great, thank you. So let's take a look now and see how this work applies to the communities that we know and love. I spoke of this earlier, and we have the citation, so if you're more interested in learning more about these particular studies, if you need copies, you can more than happy to reach out to me. I'd be happy to access a copy and email it to you if you'd like. Because I know sometimes you don't have access to scientific databases, and so I have that option now, so please let me know if you want copies of these. But for the motivational incentives for enhanced drug abuse recovery, 400 patients enrolled in NIDA's CTN study. Patients who reported cocaine, methamphetamine, or amphetamine use were enrolled in one of two treatment conditions. The first being treatment as usual, regular treatment, right, plus abstinence-based incentives. And then the other group was just the treatment as usual with no incentives, right? The control group. Received on average $120 in incentives per participant over 12 weeks, just to kind of give you a sense of the breadth there. Patients receiving incentives. Some of the outcomes from the study is that patients who received incentives in the incentive group reduced their alcohol and stimulant use when given low-cost incentives. So right there, we're already seeing really positive outcomes. Also, patients who received incentives submitted more stimulant alcohol negative samples. So as Dr. Skinstead was talking about, the negative urine sample tests. And patients receiving incentives also attended more counseling sessions and had longer periods of abstinence. It's a native-specific study looking at, let's read the title here. The title of this study is Assessing the Interest in Cultural Congruence of Contingency Management as an Intervention for Alcohol Misuse among Younger American Indian Adults. And the goal here is just to assess interest. Like, is this something that your community would be interested in? Is this something that seems like something valuable that folks might be interested in participating in? And so with this, 4 overarching themes emerged from this study. First of all, the importance of choice. That kind of, in other words, maybe another way of thinking of this is you're empowering your clients and your patients to take an active role in their care, right? Giving folks this sort of level of choice was important. Providing practical and fun prizes, offering prizes, cultural activities that capture the intention of younger adults as part of contingency management were ideal for engagement. Some of the barriers that emerged as a result of this study was related to access. How do we get to the program? How do we even find a program in our area? Questions such as that. Retention, how do we keep folks engaged? How do we get folks to the appointments back and forth? And certainly environmental factors such as potentially, if clients are living in a home where there's ongoing use, that's an environmental factor that's going to affect the outcomes, right? And intervention includes marketing and outreach to increase community involvement and intervention visibility. I think that's really important. Rather than this sort of contingency management program taking place is in the depths and the dark corners of an office somewhere in some building, there was an intentional effort to let the community know that this was going on and to educate folks about what was taking place. And I think that's a really great way to reduce stigma. Folks who may be fearful of contingency management or maybe fearful of your program or whatever the case may be, these educational outreach activities can help reduce community level stigma. Another study, hold on one second, let's make sure. It's the same study. Focus groups to increase the cultural acceptability of a contingency management intervention. Oh, no, I'm sorry, my bad. 1 second. It's a different study. Another study with Native folks. The title of this study is Focus Groups to Increase the Cultural Acceptability of a Contingency Management Intervention for American Indian Alaska Native Communities. So some of the outcomes from this study is that reinforcers should align with existing cultural and community practices and facilitate cultural and family engagement. Very broad, right? But I kind of see where they're going with this. The next finding was that contingency management needs a champion, such as an elder or a community leader, to enhance community fit and increase sustainability. I like this particular bullet because it ties into the last study in which there's a visible champion of the program who's out there, ready to handle questions, ready to talk about contingency management. A visible community leader, I think, is a great way to also reduce stigma. Additionally, implement cultural activities along with contingency management to increase community participation and integration of the intervention. And present-day implications of the history of research among Native communities must be considered. So in other words, when thinking about this work, thinking about research in general, being mindful that there is a harmful legacy of research among Native people, among indigenous communities. And so I guess another way of maybe phrasing this is like putting your patient's needs first, or being client-centered, or being patient-centered, um, being aware of their safety and their levels of comfort and their concerns around confidentiality. I mean, all that comes into play when we talk about the implications of the history of research among Native people. This is just another, it's really hard to read, but I just want to point out that looking at all the different practices that Native people are familiar with, so you think of like talk therapy, cognitive behavioral therapy, there's greater awareness around those types of activities like relapse prevention therapy. Those are more well known than, say, programs such as contingency management. Oh, I'm sorry, excuse me, I have that flipped around. My bad. It is very hard to read on that slide. Okay. Another study, and this one actually, I was reviewing it and I didn't necessarily find any Native studies. But for those of you who do not know what a systematic review is, they're actually quite handy. Instead of having to read 24 articles individually and me take notes on every single article and then have to sum up what the key findings were, a systematic review actually does that all for you. Some researchers, in this case, Oluwahi and others, 2019, conducted a systematic review which was titled The Dissemination and Implementation of Contingency Management for Substance Use Disorders. And elements identified to increase adoption. In other words, what were some of the themes that came out from all these 24 studies that we can apply towards our own work is that there was a need for collaboration when developing contingency management procedures. Everybody from the top down to the staff that's implementing the program, there had to have been like ongoing collaboration and communication to develop the procedures. There was a need to identify an implementation leader, someone who's going to be the point person to handle situations and challenges when they arise, and the need for ongoing supervision. And an interesting outcome was fidelity monitoring. So they in this particular systematic review, they listed a number of tools and measures providers and checklists providers can use, like 10-question checklists that are validated. Providers can go over these checklists with themselves to make sure that the steps were followed in the correct order and that steps were done in the correct way with regard to the fidelity of the intervention, with regard to the way in which the intervention was delivered. Certainly barriers with cost and staffing, that's seems like an ongoing one, right? And then lastly, looking at another study, titled A Culturally Tailored Behavioral Intervention Trial for Alcohol Use Disorders in 3 American Indian Communities, Rationale, Design, and Methods by McDonald and others. This was the largest randomized controlled trial of contingency management for Native folks. Included 400 Northern Plains Native individuals who suffer from alcohol or who met the criteria from alcohol use disorders. And the title is Conducting the Honoring of Our Native Ongoing Recovery, and it's study funded by National Institutes of Health. And the results of the trial are not yet published, so we are in the throes of this study. Be on the lookout, right? And you can see from this graphic the model and the flow chart and how the program is implemented. All right, so to wrap this up, and then we want to open it up to the floor, and I'll hand it back to Jeff. We know that there are going to be some challenges, right? There are some contingency management challenges. First of all, the cost of incentives. If we don't have a budget for the line item to buy the incentives, how are we going to purchase them? And then also on-site testing. That could be somewhat of a challenge. Counselor resistance, our own provider bias, if you will, our own challenges with the principles and tenets of this program. And then we could also see tribal community resistance. There might be some resistance to even beginning something like this in one's community. And there are some common concerns, right? Isn't this just rewarding patients for what they should be doing anyway? Another concern might be, how do I set up a prize cabinet to deliver prizes, those incentives? Another concern might be, does it lead to increased gambling among patients in treatment? I mean, these are all valid concerns, and we can talk about these more. And what I do know about the gambling, does it lead to increased gambling, is that is something that you would have to use clinical, somehow can perform a clinical assessment to see if this is the right fit, right? We're talking about contingency management as a tool, as a tool in your tool chest. And this tool may apply to some and it might not apply to others. And that's a discussion you would, an assessment you would have to make. And so I want to just add some perspectives from patients themselves, or for patient and provider and administrator. On the patient side, I felt that I was going down the drain with drug use, that I was going to die soon. This got me connected, got me involved in groups, and back into things. Now I'm clean and sober. And from a provider's perspective, we came to see that we need to reward people where rewards are few and far between. We use rewards as a clinical tool, not as bribery, but for recognition. The really profound rewards will come later. And then from a program administrator, the staff have heard patients say that they have come to realize that there are rewards just being with each other in the group. There are so many traumatized and sexually abused patients who are only told negative things. So when they heard something good, that helps to build their self-esteem and ego. So why contingency management? One, certainly we can increase the patient motivation to be engaged in care, to have a level of commitment, to take charge of their care. We're increasing those motivations behind wellness. A second reason why we would use contingency management is to facilitate therapeutic progress and goal attainment. Little rewards, little boosts of positive, a positive activity can go a long way. It's more than just a little kind word here and there. It's actually something the individual can walk away with in their hand and feel that immediate reward right then and there, right? The feeling of doing well is right there in that moment. And that's so critical. We can also, why we do contingency management is to improve the attitude and morale among clinicians and administrators. It's almost as if like, it's a circular effect, right? When clients are doing well and they're feeling good, we feel good. We feel excited for clients, and we want to like celebrate in that. And then when we're feeling good and excited, that kind of feeds into the client's experience when they interact with us. And so it is improving attitude and morale among everybody, I believe. And certainly we know from the evidence base of what we've seen thus far in Native communities as well as in others for decades is that there are better treatment outcomes to be had, which is why we would use contingency management. So contingency management, in conclusion, is a tool based in behavioral theory in which you reward positive behaviors. And it can be implemented in Native settings to improve treatment outcomes. And certainly want to, again, say thank you and give a shout out to Noah, Jeff, and Steve for putting this presentation together. And just kind of going to go through these, and I'll turn it back over to Jeff. Thank you.
Thanks, Matt. I do want to open it up for questions. Does anyone have questions for our presenters?
I see one question here from Shannon. What are some good prices? It's a good question. I have seen anything from toiletries to clothes to groceries, and it all depends on what is important for this participant to or client in his or her life. And if you can reach that, then that is a good price. And just remember my example, giving a man in his 50s, 60s access to diapers for babies may not be a good price because he is done with raising his children, whereas a mom is not done with that. She may feel that the expense are very high to and for that reason this would be a very very important. And LaDonna is suggesting that the price should be something related to your beliefs, native beliefs. I think that's a good point, LaDonna. But it also need then to be to a person who is to whom traditional ways of living is important. A person who is very assimilated may not find that as important, or on the contrary, feel that if she gets or he gets something like that, that would mean that they would want to go back and get to know their own culture. And Shirley Kane is referring to wild rice. That is a fabulous gift.
Is there anybody on, is anybody actually conducting or administering a contingency management program online? And if so, what are some of the examples of gifts you offer or incentives you offer? And Melissa offers that, asking the community that makes up your program. Right. So when I talked about earlier in the slides, collaboration with everyone on the administrative side, on the program side, it certainly could involve, what they would refer to as a community-based approach, in which you might have an informal or a small focus group of participants and ask them, provide us what are some ideas of gifts or incentives that you would like to see, to help facilitate recovery. That's a question you could collaborate with. Yeah, absolutely, with the target audience.
Mm-hmm. Mm-hmm. And that would also, remember, you indicated that it was important to engage the elders, engage a strong person in the community to be a opinion leader, to be a supporter of this, because then the price is developed as a community and you acknowledge it as a community and you get buy-in from the community. So that is a very good approach.
Yeah.
And
Abdel, go ahead.
Suggestions for sweetgrass blankets, Pendleton towels. All these things are important and very good ideas. And one thing that I want to sorry.
Oh, go ahead.
One thing that I want to say, I know that Amy and will go over this more in detail, but what I really want to say also is that when we were working on the contingency management, or what we call the PAMI awareness project in the 2002, early 2010s, we discovered that actually purchasing of incentives would and could be covered by Medicare as part of a treatment approach. But I know that Amy and Will have things they want to share with you too. Mm-hmm.
Speaking of which, we do want to keep answering your questions, but I'd like to turn this over now to William Longinetti and Amy Romero, two of the government program officers for the Tribal Opioid Response Grant.
Hi, good afternoon, everyone. This is Amy Romero, and I'm one of the TOR GPOs. I will provide some guidance on how you can use your TOR grant to implement contingency management. This is an evidence-based practice, and I encourage you to use it. Next slide, please. So actually, I can move the slide. The new TOR funding opportunity announcement includes specific guidance about contingency management. Grantees that will be funded on September 2020 are able to provide non-cash incentives for the value of $15 or less, and totally no more than $75 per year, and that is listed on the FOA. You all were funded in 2018 or 2019 and are able to provide programmatic incentives as part of the client's treatment plan. If you're planning on implementing contingency management with your current grant, you're able to do that. There are no specific limits set, but we encourage you to contact your GPO and we can work with you on the implementation of this evidence-based practice. In addition to the programmatic incentives, the TOR program allows you to provide incentives for GIPRA data collection, and these are separate incentives. And you can provide a $30 non-cash incentive during the GIPRA follow-up interview and another $30 incentive during the GIPRA discharge, for no more than $60 per client. You can use your TOR grant to provide additional support for your clients. Our goal is to ensure that your clients are successful in treatment and recovery. You can provide transportation as part of your TOR grant. Some examples of transportation costs include bus cards, bus passes, Uber rides, but it's not just limited to those. These are some examples that we have seen that grantees are using, but you can provide any type of transportation that is needed in your region. We also encourage TOR grantees to provide culturally appropriate and traditional practices, and you can use funding for supplies for those activities. Things like crafts, pottery, basket weaving. Some grantees are using funds for fishing, expeditions, retreats. And again, it's not just limited to those. It could be any applicable culturally practices. SAMS allows grantees to provide light snacks for the value of $3 per person. And we know that that's very little, but it can also, help incentivize participation in some activities. You can provide an array of services for recovery programs. Many grantees are offering health and nutrition classes. I have seen other programs that are offering traditional cooking classes. And programs get very creative on how they implement the recovery program, but you can create something that is very specific to your community. Other grantees are providing skill building sessions, such as financial classes, to help clients learn how to manage their finances. Also, employment assistance that can help clients learn how to have successful interviews or link them to employment in the community with local businesses. We recommend that you ask your clients, as Helene stated before, what do they need in order to be successful in treatment? And the incentives have to be appropriate for them. Some may need hygiene products, others may need grocery gift cards, or assistance with childcare to be able to attend treatment sessions. So we're not able to provide funds, and that is a request that we have received very frequently recently. But during this time of COVID-19, many programs are providing calling cards to stay connected with their client via phone, so you are able to use TOR funds for calling cards. And these are just some examples that we wanted to share with you. But if you have ideas or you're not sure about other incentives that you would like to provide to incentivize your clients and to implement a contingency management program, please contact your GPO. Our contact information is listed, and we can discuss those with you. Thank you, and I could take some questions.
Thanks, Amy. Do we have any questions for the presenters or the government program officers?
Well, while we're waiting, I see some people typing. I like Mike Ortiz's idea. He says, we have an outpatient program here. What I found effective along this approach is the use of art supplies. So drawing paper and pencils when a strength along this line is identified. Yeah, so if you have clients who are artists, art supplies, those can be expensive, right? And I think, and then he says, do you think that expanding this avenue to include a small art show may have an additional positive results to infiltrate the community? And I think absolutely, right? It's in other words, you're almost like becoming the champ. You are the champion in a sense that you are working to raise awareness, to build up your clients, and share some art. What could be better than that, right?
And I want to reinforce that in a different way, Matt, because if you create an art show that includes patients and non-patients, then you are you're working actually on reducing stigma, because then they are, as clients, able to show, well, look here, I have been without any drug addiction for a long time, and when I am able to paint, I'm able to bead, I may be able to do some wood carving, and those things are really very very great experiences. And I have to say, the times when I have been in tribal communities and traveling to treatment centers, I have enjoyed specifically some of the woodwork and the beadwork that has been accomplished through support from the treatment program. I think that's a very important thing to do.
Great. Yeah, there is a question from Annette regarding the providing incentive for the GIPRA intake. And unfortunately, we cannot provide the $30 incentive for the GIPRA intake, but only for the follow-up and the discharge. You are able to provide transportation, childcare, or other things that your client may need during the intake, but you cannot provide, for example, a $30 gift card for the intake. And then I see that someone is also providing rental assistance, and that is allowable with TOR funding to provide recovery housing or short-term rental as well. Yeah, and I see that other programs are providing yoga classes that fit into a healthy recovery, fitness, and that's also allowable, yes.
And I want to add something, Amy, to why the intake is not reinforced. Because the intake oftentimes, yes, it is an accomplishment. We have a Norwegian saying that often the largest mile is to cross the entrance. But what this is meant to be is to be a reinforcing mechanism to a positive behavior and a behavior associated with the treatment plan. And when people come to intake, they may or may not be 100% sure that they're going to go for this. So their motivation may be a little shaky, and it's understandable that the reinforcers come at discharge and follow-up.
Yes, that is correct, Angeli.
But I want to also address this issue of, I remember when we started working on this about 15 years ago, this issue of us as counselors saying, why on earth are we going to give something to somebody who is doing what they're supposed to be doing? Mm. That issue and that attitude among us as professionals was really deep-seated. So a lot of us had to really go in ourselves and say to ourselves, now, do we really think that that's bad? We had to sort of change our attitude a little and then be convincing role model that yes, this is worthy. Think about AA and NA. When you have gotten your first coin for sobriety, that's a huge accomplishment. And we've done this for years, but it hasn't been systematically studied like it has been in the last 40, 50 years. AA started this in 35, as you know.
And if any questions come up, please feel free to contact Will or I, and we can respond to questions after the webinar.
And I want to throw out a question to all of you. Was this helpful? Was this a new way of thinking? Let us know a little bit how your thoughts are, because we wanted to make sure that this topic was clear for you all so you knew how to do that within the framework of the TOR grant.
And it looks like we have a question from Shirley. Does contingency management affect the final outcomes for clients?
Yes, it does, because we can see from both short-term and long-term studies that the length of sobriety and the stability of recovery is better with the use of contingency management. It's a very good addition to treatment, whichever treatment is preferred. And Joanne, you have a comment here. Can you address that? Do you have the ability to address it? I don't know how to unmute you.
I don't think so, but Joanne says we have few people from a recovery group that meets with patients with those in physical rehab and occupational therapy recovering from severe and disabling spinal injuries. And they make t-shirts and silver jewelry together.
And Annette Hubbard, my buddy from the NILCHEC, is asking of the group on today's call, does anyone have a format or spreadsheet that they'd be willing to share with regard to your contingency management program? Annette would like to know.
When you're talking about the spreadsheet, is that in addition to what you do for the client, or is it sort of creating an overview of what kind of incentives and how frequently they have cashed in their incentives? I'm not sure. I need a little bit of clarification.
Yes, also Shirley says it would be helpful to give grantees written material. Can we do that for people who did not join? And sure, Will and I could put together an email for all tour grantees, including some of the guidance that is listed on the FOA, including some of the examples that we have seen grantees are using.
I think that would be very helpful. Yes, because then you have examples. But what we also would be able to do is to share the PowerPoints we have developed with people who are not able to be on the call. And what I think we should tell people who aren't able to be on the call is that if they review the PowerPoint and have questions, they can approach Matt, Jeff, or myself, and we will try to answer the questions that you might have.
Yeah.
Now I see what Annette wanted. You are talking at active abusers who you want to engage. So you want to keep track of who gets what and when. And I see that as a very good idea. It can be done both as a institutional overview, but also as an overview in the client's record to keep track of how. And also, I would say to keep track of what clients like, because I think it's important for the incentives to be valuable, they have to have value for the person that you are working with. And this issue of incentives, I know, Matt, you have used food as incentives for participating in your project. And I think that is an incentive as well. So do you want to address how you use that?
Well, I guess if I'm applying those experiences into this model, you know, we might put together like get a couple cooks to maybe cook a dish, and we put together a little feeding and invite the community to come learn more about contingency management. We might use food as an incentive in that way, in sort of these initial community or even ongoing community town hall discussions, these sort of educational forums where folks can learn more about what's going on. I could see food as a quote unquote incentive being used at that stage. What I also like is that there's a $3 per person allotment for food, throughout the duration of the program. So I was thinking, well, how do you get around that? And how do you supply nutritious snacks? And I was already thinking if it were me and I had $3 per client, I could potentially go and purchase things at the dollar store, 3 different items per person, and then sort of make little care packages as a contingency management or as a food incentive to meet the $3 requirement. Um, so and then you have to layer on the native cultural piece, which is like food is um, it's the great unifier. It's ingrained in our traditions. And so how do you meet that need throughout the program when you got $3 per person? I think if I sat down and thought around this and came up with some ideas, I think there's a way to work this, and certainly we'd be happy to entertain those discussions with folks around what that might look like.
And
That was a very long answer to say I'm not quite sure what that would look like, but I'm willing to engage in those conversations for sure.
Yeah, yeah. And one thing that I want to add also, but now the pandemic notwithstanding, I mean, there are things we can do today that we should not do when we have, or we could do in the past that we shouldn't do with the pandemic in mind. And one of the things that I used to always engage women in my treatment unit in was to make food and to learn to cook and to do that in a traditional way. And that was Norwegian, but we have traditional foods too. And I know the tribes certainly do. And it's one of those things, how to make traditional food with healing qualities, and that goes into ceremony. I think the combination of food and ceremonies in a way is very strong when it comes to culture. And as a Native person, you're not supposed to be intoxicated when you are participating in ceremonies. So that could also be built into a program of incentives.
Yeah, for $3 a person, you could buy bulk ingredients, right? And then like teach a traditional bread making class, like traditional bread, not
Yeah.
I'm thinking of traditional foods. But that could be a
Yeah.
reward. It could be an incentive. Yeah.
Yeah, but just to clarify, the $3 limit per person, that is per one time. So if you're having an event or some type of group session, it's $3 for that day. It's not $3 for the entire program.
Okay, got you. That's good to know.
That's very important information because that makes it not as restrictive as we might have thought in the beginning.
Yes. So it's if there isn't a specific, I mean, you're not able to do it every single day, but if there isn't a specific activity or event that may require your clients to come for for a couple of hours, and you think it'd be a good idea to provide some light snacks, it's something that you can do. I would say it shouldn't be a daily occurrence for every treatment session, but it could be, once a week or something like that.
Mm-hmm.
Great, thank you.
Mm-hmm. But we do know the importance of connecting this to culture and how culture is prevention, and how when you connect food to cultural events, then that also becomes a protective factor against relapse. So I think thinking about this in a holistic way, which is what I know a lot of my Native colleagues do, I think you can come up with a very nice program for clients that will make clients want to come.
Okay, well, I'm not seeing many more questions in the chat, so I think I'm going to bring this to a close. Anna Helena, Matt, do you have any other closing remarks you want to make?
It's been great to visit with you all for this afternoon. Please feel free to reach out if you have any questions.
I have become very excited about all your ideas and all your suggestions and enthusiasm. So I look forward to hearing more about how you implement a contingency management in your tour project. And, you know, if you start implementing and you have issues, let's see if we can use one of our meetings to discuss what the issues could be and would be and how we can help you support them. Because I think all your ideas are very invigorating for me as an old clinician. So good luck. I really think this can be great. And thank you all for all your input. Back to you, Jeff.
Okay. And again, if you have ideas for other webinars or concerns about different aspects of the TOR grant that you'd like to see addressed in the webinar, please just let me know. You can contact me at my email, which you can find in the contact box.
And I like also the issue that Joanne raised, which was to engage the community members and the clients in promoting this and also developing a social enterprise program.
And you are able to do that with I don't see any issues with the TOR grant doing that, as long as, you know, all of the funding goes back into the TOR grant for incentives for the clients.
Thank you, Amy, for that clarification. I forgot that part. Of course. Yes.
All right. Thank you all for joining. And please just take the 5 minutes to fill out our GIPRA survey at the end here. Have a good Tuesday.
Thank you.
Thank you.
And bye.